All right, class, let's go over these 4 problems on ABG interpretations. First of all, before you even want to interpret these results of your arterial blood gases, you need to know the normal of the ranges. pH is 7.35 to 7.45. PO2 is obviously, we like to see at least, 80% are PaO2s. Otherwise, if it's below that, it's usually what we consider the patient to be hypoxic. Then our carbon dioxide levels is 35 to 45 millimeters of mercury. And then our bicarb is 22 to 26 milliequivalents per liter. So you have to maybe in the beginning memorize those normal ranges in order for you to determine if these results are out of those ranges, okay? All right, so let's look at the first one. We look at the pH first, and we see that it is 7.48. Can anybody think about whether or not this is more acidic or more alkalotic? Now think about it. Anything below, going to the left on the scale, below 7.35 would be considered acidic, and anything going to the right above 7.45 is considered alkalotic. So right away we know that the pH is alkalotic, correct? Because it's above 7.45. All right, so we've determined that. Let's look at the PaCO2, which is really basically looking at our respiratory function and looking at the acid. So we look at the results here, and it's 30. So anything below 35, we're going to the left on the scale, would be more alkalotic, and anything above 45, we're getting more acidic. So our results here are 30. So that would be more on the alkalotic range. And then we look at our bicarb, our HCO3, and it's 24, and that's within normal range. So the answer to this problem is respiratory alkalosis. All right? I hope that makes sense to you, okay? Please, in order to do these problems, I was hoping that you would look at the video on Pearson, and then definitely read your assigned reading from pages 3 through 12 in your Pearson book, okay? As I said before, you have to know the normal ranges before you're able to determine what problem is going on with your patient when these results come back. All right, let's look at the second pH, 7.52. Now that's going to the right on the scale. It's above 7.45, so it's alkalosis. Our PaCO2 is 43. The range is between 35 and 45, so our CO2 levels are normal. So let's look at our bicarb. It's 31. So it's above the 26, so when it goes to the right, it is more alkalotic. So the answer for this is metabolic alkalosis. And when anything is abnormal within the bicarb, that represents a metabolic problem. Okay? All right, let's look at number 3. pH is 7.26. Think about where that is going on the scale. Is it going more to the left? Is it going more to the right? It's definitely below 7.35. So going to the left, it's acidotic. Our PaCO2 is 35 to 45. That's still within the normal range, even though it's high normal. And then our bicarb is 16, which is below 22, going to the left on the scale. So the answer is metabolic acidosis. And then the last one is a pH of 7.28, which again is below the 7.35, which is acidotic. And then your PCO2 is 52, which is above 45, which is going to the right, which means it's more acidotic. And then your bicarb is 25, which is between 22 and 26, which is in the normal range. So the problem here is a respiratory problem because your CO2 is abnormal. And so the answer to this is respiratory acidosis. Now, I'm not sure if all of you understand this. Obviously, we could talk a little bit about this in our WebEx this week, but in order for you to understand this, you may have to read the assigned reading a couple times, and definitely review the Pearson video as well, okay? I could give you a little bit of more helpful information. I try to teach students this by looking at this acronym called ROME, which is capital R, capital O, capital M, and capital E. And what I mean by this is that stands for respiratory opposite and metabolic equal, meaning in regards to the pH. And what I mean by that is this can get a little bit confusing. That's why it's important that you reviewed and looked at the Pearson video. When we're talking about the carbon dioxide, when it goes left, all right, it's more alkalotic, meaning when it's below 35, it's more alkalotic. But if you compare that to the pH, if you go left on the pH scale, below 7.35, it's more acidotic. So it's opposite respiratory. But then you look at the HCO3, and when you go left, meaning below 22, it's more acidotic, and that's in comparison with the same way that the pH scale goes as well. So that's what I mean by the ROME acronym, respiratory opposite, metabolic equal, in reference to comparing the scales of the bicarb to the pH. When they go in the same direction, they're both acidic or alkalotic, but when you talk about the pH and the PaCO2, when you go left on the PaCO2 scale, it's alkalotic, but when you go left on the pH scale, it's acidotic. So that's what I mean by respiratory opposite, metabolic equal. So hopefully that helps a little bit. So that's pretty much all I have as far as arterial blood gases. We're going to talk just a few minutes about pneumonia. But again, make sure you read your assigned reading and make sure that you review the Pearson video. Because all we want you to understand within blood gases is knowing the normal ranges for each of the components of arterial blood gases, and then knowing whether or not it's acidic or alkalotic, and that's determined by the pH, and whether or not it's a respiratory problem or a metabolic problem. Respiratory problem, you would see the PaCO2 out of whack and outside the parameters of the normal range. If it's a metabolic problem, you're going to see the bicarb out of range. So that's how you determine if it's one problem or the other. All right? So that's all we need to know so far in Nursing 121 when it comes to arterial blood gases. All right, class, we're going to talk about this exemplar of pneumonia, okay? And pneumonia is a very serious illness that we are still seeing people die of every year. It's an inflammatory process that occurs in the interstitial space, in the alveoli, and often in the bronchioles. And so what has to happen is the organism has to get into the lungs. It has to move down into the alveolar space, and they actually have to survive the inflammatory process. And what then happens is you have white blood cells that migrate to that area of infection, causing capillary leak, edema, and exudate. And you have fluid that collects in and around the alveoli. And just think about what that area for the alveoli membrane does. That's where the diffusion of gases takes place. And unfortunately, when those fluids start to collect around that alveoli space, it causes the alveolar walls to thicken. So it will reduce gas exchange and lead to hypoxia. And then this capillary leak spreads to other parts of the lung. And this is why we see patients develop a lot of complications from pneumonia. All right, so I've got this PowerPoint in front of us. It's very detailed, but it really does give a great overview of exactly what is happening with a patient when he develops pneumonia. All right, it's inflammation of the lung parenchyma, and parenchyma is just a fancy term for tissue. And the respiratory system is open to infection, and this is definitely in that population that are immunosuppressed or have respiratory illnesses. And of course, it's disorders that affect lower respiratory system, that affect the ability to ventilate, they affect respiration, and affect the ability to maintain airways. So organisms will enter the lungs in several ways, and that can happen through aspiration, you can inhale them, and obviously through bloodstream from infection in the body. So the organisms actually colonize or kind of gather in the alveoli, and it initiates, as I said before, the inflammatory and immune response, causing fluid to accumulate in the alveoli, and then fluid leaks into the interstitial tissues. And these are the ways in which the pneumonia can develop. It can be in the lobes, called lobar pneumonia, the bronchial pneumonia caused in the bronchial and interstitial pneumonia, and also miliary pneumonia. And miliary pneumonia is just a term that means multiple discrete lesions resulting from the spread of the pathogen to the lungs via the bloodstream. And there's different types of miliary respiratory problems, like you can have miliary tuberculosis, histoplasmosis, things like that. So that's what that particular type of pneumonia or pattern kind of looks like. And pathological processes varies according to what particular organism invades that area in the lungs. You can have bacterial pathogens, viruses, aspirations, could be from a chemical injury that of course lead to that inflammatory response, and again then they're open to bacterial invasions. They may be infectious or non-infectious, can be caused by a bacteria, a virus, a fungi, a protozoa, or other kinds of things such as a toxic or irritating gas. It can be either community acquired, or you get it out in your community, or you could also acquire it as a patient in the hospital, and that's what we mean by healthcare associated, or even on opportunistic type of infection as well, where the person is immunocompromised and it's a perfect opportunity for the infection to occur. We're pretty familiar with bacterial pneumonia. It's a pathogenesis of pneumococcal pneumonia. Bacteria reside in the upper respiratory tract, and of course you have the inflammatory response, which results in alveolar edema, formation of exudate, which is pretty much all those secretions that somebody with pneumonia gets, and some consolidation of the lung tissue. Typically resolves uneventfully. All right. The thing we worry about with pneumonia is the complications that can occur, such as pleuritis, where there's an inflammation in that pleural lining, causing a lot of pain, especially on inspiration. Pleural effusion, where the patient accumulates more fluid in that pleural space. Maybe this is why they have to have what we just talked about, such as a thoracentesis, a lung abscess, empyema, or thoracentesis. All right. And an empyema is when there is a collection of pus in that pleural cavity, and very often related to somebody who does develop pneumonia as a complication, or sometimes we see it develop after thoracic surgery or even thoracic trauma. So that's what empyema is. Acute bacterial pneumonia, usually acute, which has an insidious onset, which means that it begins to happen gradually or very subtly, but unfortunately presents with harmful effects. These are other types of pneumonia. May heard of Legionnaire's disease, caused by the Legionella pneumophilia. It's a gram-negative bacteria found in water, gradual development, consolidation of the lung tissue, and a patchy and lobar type of pneumonia. Another primary atypical pneumonia is mycoplasma pneumonia. Of course, differ from those of other bacterial pneumonias where you have patchy inflammatory changes in alveolar septum and interstitial tissue of the lungs. It's highly contagious, and this is what you might have heard as the late term of walking pneumonia. All right. And viral pneumonia and some of the common organisms are influenza and adenovirus, typically a mild disease. And then this other one is pneumocystis jirovecii pneumonia. It's what we call an opportunistic pneumonia. You see this happen with people that might have AIDS, that are significantly immunocompromised, patchy involvement throughout the lungs, the alveoli thicken, become edematous, fill with foamy, protein-rich fluid, a very abrupt onset. And then aspiration pneumonia, where you might aspirate gastric contents, could be a type of chemical and bacterial pneumonia. And we know that in the stomach, the pH is very low and can cause complications such as abscesses, bronchiectasis, and gangrene of pulmonary tissues. So who is at risk for developing pneumonia? Obviously, an immature immune system, infants, young children, older adults, people that have a diminished gag or cough reflex, a compromised immune system, people that are exposed to cigarette smoke, not only people who smoke, but also secondary smoke as well, people who abuse alcohol or drugs, and have a higher risk for adverse outcomes. And prevention is to identify those vulnerable populations and to be sure we identify what is the infecting organism. We might do that by sputum analysis such as CNS, and encouraging the community, especially people over 65 years of age and ones that have an immunocompromised system, to get their pneumococcal vaccine and an annual influenza vaccine as well. So what does the patient present as when he develops pneumonia? Cough, excessive mucus production, dyspnea to different degrees of shortness of breath, hemoptysis, chest pain. Systemic effects are fever, diminished appetite, cyanosis, which is very severe, or respiratory problems can lead to respiratory failure, and definitely manifestations of impaired gas exchange. Remember that alveoli wall is all thickened, so it's definitely affecting the diffusion of gases. Remember, when we talk about age groups over the lifespan, children's airways are shorter and narrower. Tracheal increases in length in the first 5 years, and narrower airway causes increase in resistance. Remember, at birth, only about 25 million alveoli, greater in clinical impact. Pneumonia often resolves much sooner. Remember, children under 6 use diaphragm to breathe. That's where it leads to retractions, which is a late sign of respiratory distress in adults. Oxygen consumption higher in children. They become hypoxic more quickly than adults. Clinical manifestations where the effect of pneumonia could be sepsis, leading to septic shock and possible death. With older adults, another reason why they may be more prone to pneumonia is the number of cilia decreases, gag and cough reflex diminish, greater risk for dehydration, especially with fever, and their immune system really declines as one ages. So in order to help these patients overcome the illness, we collaborate with respiratory therapists, infectious disease specialists, physicians, radiologists, pulmonologists, and phlebotomists. They're going to have oxygen therapy. Many of them do. Might want to call in an infectious disease specialist, especially if they're not responding to antibiotics and they're developing some of these complications. Obviously, the healthcare provider is an important person, x-ray techs and radiologists who read those x-rays, and of course, a specialist, pulmonologist, and then of course, a lot of labs are done where the phlebotomists come in and draw lab work for the patients, okay? Other types of diagnostic testing, chest x-rays, CT scans, sputum culture and sensitivity, and CBC with WBC differential. If it's caused by a bacterial, we're going to see specific white blood cells elevated during the exacerbation of their infection. History, physical exam with diagnostic testing, serology testing, pulse ox, arterial blood gases, and possible bronchoscopy. Antibiotics after gram stain, chest x-ray, antibiotics for selected pneumonias. Many times because of the inflammatory process, they might be ordered bronchodilators, and some of the sympathomimetic drugs or the methylxanthine, such as Theodora, aminophylline, and then of course agents to help break up the mucus, acetylcysteine, potassium iodide, and guaifenesin, and of course to increase fluid intake. Many of them might have IVs to prevent dehydration as well. Again, systematic therapy and supportive care, making sure patients are doing spirometry, oxygen therapy depending on their degree of hypoxia, and increasing fluid intake as well. Sometimes respiratory therapy may come in and do chest physiotherapy. It's called postural drainage, where they'll clap on the chest to help bring up some of the secretions, used for percussion, vibration, and postural drainage as well. Nursing process, we look at some of our patients. This can go anywhere from a minor case to a very severe case. That's why they need frequent pulmonary assessments, aggressive interventions, and promoting adequate fluid intake, meaning that they're hydrated well enough so that adequate vascular volume perfusion, making sure the patients are putting out enough urine, and looking at the patient to make sure they're being oxygenated as well. Really looking at their health history, how do they present, what's their current symptoms, how long have they had these problems, what other comorbidities, other chronic diseases that the patient may have will affect their prognosis, recent upper respiratory infections, what medications are they on, looking at how much distress, how much shortness of breath, and what are the difference between adults versus pediatric patients. These are some of the nursing diagnoses we may see: ineffective airway clearance because of all the secretions, ineffective breathing pattern, hyperthermia, activity intolerance, anxiety related to hypoxia, imbalanced nutrition less than body requirements, and disturbed sleep pattern related to orthopnea, which means they can't lay flat because they're very short of breath. So that's what orthopnea is. Just to mention, patients that have a real serious form of pneumonia are very, very sick. And that's what's going on with this coronavirus. Basically what this is a aggravated case of pneumonia where there is problems with the alveoli and the patients have severe hypoxia, problem with diffusion of gases, and they go into respiratory failure, and that's why some of them have to be put on ventilators and be taken care of in the critical care units in the intensive care unit. So basically this is what's going on with the coronavirus. Planning, keep the temperature down, adequate fluid and caloric intake. As that fever increases, their metabolic needs also increase, and that's why they need enough calories. They're very sick, they're very tired, they feel general malaise. It's hard for them to sleep because they are in some respiratory distress. They get worn out by trying to cough because of all the secretions, and sometimes they're too tired to really have a fair enough cough reflex to clear their airways. And some of them may or may not require supplemental oxygen. They may be on antibiotics or other medications, again supporting optimal respiratory status such as maintaining airway patency, effective breathing pattern, and promoting rest to reduce metabolic and oxygen needs that they may unfortunately warrant to improve their respiratory status. Assess respiratory status at least every 4 hours. If they're in a critical care unit, they're probably going to be assessed every hour, assessing cough and sputum, monitoring ABGs, placed in Fowler's or high Fowler's position just so they are comfortable and not in any respiratory distress. And here we have to again assist coughing, deep breathing using devices such as incentive spirometry and making sure they're taking at least 2,500 to 3,000 milliliters of fluid. Collaboration to provide good pulmonary hygiene and give medications as ordered. And remember, these patients are going to be somewhat anxious. When you can't breathe or you have difficulty breathing, people get scared, okay? Ensure effective ventilation, provide rest periods, assess for pleuritic discomfort, teach patient how to splint their chest. Sometimes I used to fold a bath blanket and have them hold it across their chest so that when they took a deep breath to cough, it didn't hurt as bad. It was kind of like splinting the area. Provide reassurance during respiratory distress to help relieve a lot of their anxiety, give them their oxygen, and teach them about slow abdominal breathing and relaxation. Promote the balance between activity and rest, assess activity tolerance, help them with self-care activities. They may not be able to give themselves a bath. You may want to assist them so they don't use all their energy for that. Provide assistive devices. Enlist families help to minimize stress and anxiety. Perform active or passive range of motions, range of motion exercises, and promote emotional support and reassurance. Community-based care, complete prescribed medication, as many of them will go home on their antibiotics. Make sure they take the full prescription. Recommendations for limiting activities, making sure that they continue to drink fluids, and start slowly on intaking meeting their nutritional needs. If they've been smoking, not to smoke, and to be away from secondhand smoke as well, and teach them what to do if they about the signs of reoccurring infection, and then to report those findings to their physician as necessary and as soon as possible. And a lot of this teaching can also be given to family as well. signs and symptoms, and then when to call the primary provider, okay, or the nurse practitioner who's in the office. So that's pretty much a recap of pneumonia. There's also a Pearson video that's in your modules in week 4. Please review that. It's very short, so make sure you look at that, okay? So now what we're going to do is some activities related to pneumonia, all right? Okay, if you get out Appendix 21, we're going to talk about nursing interventions, about what we would do for our patients who have pneumonia, and this is based on scientific research. So what I want you to think about as we talk about these nursing interventions, what is the rationale behind them, okay? Why do we do what we do, all right? So, assess the rate and depth of respirations and chest movement. Obviously, we watch for signs of tachypnea, shallow respirations, and asymmetric chest movements are frequently present because of the discomfort of moving the chest wall and or fluid in the lung. Sometimes it takes, it really hurts to take in that deep breath. So you'll notice that some patients do kind of decrease their inspiration efforts to avoid experiencing that pain when they take a deep breath in. And we don't want that to happen because this is where we could see fluid build up and the inability to get that those secretions out of their lungs as well. Auscultate lung fields, noting areas of decreased or absent airflow and adventitious breath sounds, crackles, and wheezes. Decreased airflow occurs in areas with consolidated fluid. Bronchial breath sounds can also occur in these consolidated areas. You might hear crackles, rhonchi, and wheezes are heard on inspiration and or expiration in response to fluid accumulation, excretions, and airway spasms and obstructions. Remember, these are all the areas and the structures where this disease process is occurring. So you may see or hear different types of adventitious breath sounds with these patients, okay? A lot of times the wheezes can get better, the rhonchi can get better when the patients start actually clearing out that airway. And that's why a lot of times when there are wheezes, because the disease is in the bronchioles, this is where they might benefit from those bronchodilators that kind of open up those airways to allow for better airflow. Elevating the head of the bed, changing positions. Doing so would lower the diaphragm and promote chest expansion, aeration of lung segments, mobilization, and expectoration of secretions as well. Teaching and assisting patients with proper deep breathing exercises. Demonstrate proper splinting of chest and effective coughing while in an upright position. Encourage him to do so often. Deep breathing exercises will facilitate maximum expansion of the lungs and smaller airways. Coughing is a reflex and natural self-cleaning mechanism that assists the cilia to maintain patent airways. Splinting reduces chest discomfort, and an upright position favors deeper and more forceful cough effort. Suction, as indicated, frequent coughing, adventitious breath sounds, desaturation related to airway secretions. Stimulates coughing or mechanically clears airway in a patient who wasn't able to do so because of an effective cough or decreased level of consciousness. Sometimes we do have to get in there and kind of help these patients, but it should be done under supervision, or if you have some basic knowledge and experience in suctioning. Because remember, as we suction out secretions, we also suction out the oxygen, and we want to be very careful we don't cause problems. Force fluids, I like the word better, encourage, at least 3,000 milliliters a day, unless contraindicated, such as a patient have a heart failure. Offer warm rather than cold fluids. Fluids, especially warm fluids, will aid in the mobilization and expectoration of secretions, okay? Assist and monitor effects of nebulizer. Let me bring this up a little bit. of nebulizer treatment and other respiratory physiotherapy, incentive spirometry, IPB, percussion, postural drainage, perform treatments between meals, and limit fluids when appropriate. Nebulizers and other respiratory therapy facilitates liquefaction and expectoration of secretions. Postural drainage may not be as effective in interstitial pneumonias or those causing alveolar exudate or destruction. Coordination of treatments and oral intake reduce likelihood of vomiting or coughing with coughing and expectorations. Administer medications as indicated, some of your mucolytics, expectorants, bronchodilators, and analgesics. Aids in reduction of bronchospasms and mobilization of secretions. Analgesics are given to improve cough effort by reducing discomfort, but should be used cautiously because they can decrease cough effort and depress respirations. Alright, so let's continue with these. Provide supplemental fluids, IVs, monitor serial chest x-rays, ABGs, pulse oximetry readings. Followers progress in effects of the disease process, therapeutic regimen, and may facilitate necessary alterations in therapy. Obviously, these are some of the more common types of diagnostics that we'll do. Some of these patients may have a chest x-ray every day for maybe 3 or 4 days, and of course ABGs, especially in the beginning when we're monitoring their saturation and maybe their oxygen devices to see if it's hoping to prevent hypoxia and raising their PaO2s. Assist with bronchoscopy and or thoracentesis if indicated. Occasionally the patient will need one of these types of procedures to help remove mucus plugs, drain purulent secretions, and or prevent or remedy their atelectasis that's occurring. And you urge all bedridden and post-op patients to perform deep breathing and coughing exercises frequently to help promote full aeration and drainage of secretions, and also not to see other complications such as clots or pulmonary emboli or things like that when patients are very ill, as well as decreased mobility and their patients aren't moving around as well. So that's Appendix 21, which has to do with nursing interventions and why we do what we do. Okay? A short case study, and I want you to kind of think about what were this patient's risk factors and kind of look at his presentation of his particular case of pneumonia. So we have Mr. Thomas is a 36-year-old construction worker who works in heating and air conditioning. He installs the systems on buildings that are being renovated. He has a significant smoking history of 20 packs per year, and he is admitted to the hospital for a diagnosis of pneumonia. He states that he's had a cough for 2 weeks and was coughing up yellow-green sputum. The last 2 days he has had pain with coughing. His x-ray confirms the diagnosis, and your assessment reveals diminished breath sounds bilaterally with crackles and bronchi. He has had difficulty handling all of the mucus, and he states that since it hurts to cough, I try not to. Develop a concept map for Mr. Thomas with his current respiratory status. Think about this. This man is only 36 years old, and we can kind of look at what his risk factors are. He's been smoking a long time, so he has probably the beginnings of COPD, and he's around a lot of materials related to heating and air conditioning. He's working in buildings that are renovated. Maybe he works with a lot of dust and kind of detrimental particles. Could be even asbestos as well. We're not sure if he's wearing protective equipment to prevent inhaling some of those substances, especially if they're very, very old buildings. We don't know if he has any other health issues. We don't know, his size, but these are pretty significant, that his occupation and the fact that he smokes really contributes to him definitely being more at risk for developing pneumonia. Looks like he's pretty sick. It's very typical for the sputum to be kind of exhibited as a yellow-green sputum. That's many times we'll see a Pseudomonas type of infection because of the color of the sputum. And he's having a lot of pain. His lungs sound really nasty. He's got crackles, he's got rhonchi, and he's got a lot of mucus, which is really probably affecting his oxygenation as well. He's in a lot of pain, and you know, it's not good that he's not coughing, because we don't want those secretions to kind of stay stagnant and not come up. And this is why we would definitely assess his pain level and get him something for pain. So I want you to think a little bit about this case study, the case study, but also a concept map, just very basic. We don't have a whole lot of information. Obviously, in that first circle, he's a 36-year-old smoker. He's a history of construction work, heating and air conditioning. And he's had a cough for 2 weeks, and he's been coughing up yellow-green sputum. And along with the cough, he has pain with coughing, okay? So the patient problem is he's been coughing for 2 weeks. His breath sounds are representative of adventitious sounds such as crackles and rhonchi, pain with cough, and again that yellow-green sputum. He has definitely altered oxygen as related to symptoms of cough for 2 weeks and yellow-green sputum and the presence of crackles and rhonchi. And when we look at nursing interventions, it could be very much about what I just talked about with the interventions that we just went over as far as the rationale, because you want to provide nursing interventions that are based in scientific research. So, of course, we talked about deep breathing, we talked about splinting. We'd really want to provide ways in which, when he returns home, to possibly quit smoking, positioning right now, administering analgesics for pain. He might also benefit from respiratory treatments as well to help facilitate expectorating the mucus as well. And of course, expected outcomes, we would want to see a decreased amount of pain, maybe within 48 hours, and obviously decreased amount of sputum. And obviously he's probably significantly short of breath as well, since he has had a history of smoking and has developed a very serious case of pneumonia. So don't forget, as we look at those expected outcomes, we think of those outcomes that are related to the SMART acronym: specific, measurable, attainable, realistic, and timeable. So you might want to provide outcomes related to that SMART acronym. So that's Appendix 22. So hopefully that gives you a little bit more practice with the concept maps. All right, and then lastly, what we're going to do is look at this particular case study. I don't know if you have this one. Maybe not. Okay, we don't have to do that one. But I had another case study. And I'll read it to you a little bit because it's really a good one. Let me scan it, and then I'll put it up here on the computer for you. All right, here's another case study I just wanted you to kind of read through. Jimmy Bly is a 78-year-old Caucasian man with moderate emphysema and hearing loss. He is a retired veteran who served as an electronics technician in the Army for his entire career. In his retirement, Mr. Bly has taken an interest in computers. He spends most of his time surfing the internet or playing games on the computer. He also likes to build computers. Mr. Bly has been married for 56 years to his wife Cecilia. They argue a lot, but they would not know what to do without one another. They have several grown children, grandchildren, and great-grandchildren who live in the same community. Mr. Bly often goes with his wife to the neighborhood senior center for bingo night. Mr. Bly considers himself healthy. He describes his hearing loss as mild. He has a hearing aid, but he does not like to wear it and therefore does not make changing the batteries a priority. He does not perceive his hearing loss to be much of a problem. Likewise, Mr. Bly describes his emphysema as not that bad. However, he becomes short of breath with most activities, thus it takes time for him to complete tasks. He compensates by taking his time to do most things. He has learned that he must pace himself. If he does not, he becomes exhausted and needs several days to recover. He continues to smoke and he knows he should quit, but he just can't seem to get interested in quitting because he enjoys it. One night, Jimmy is awakened from sleep feeling as though he can't catch his breath. He sits up and his breathing becomes a little easier and he feels slightly less anxious. However, he also notices he is hot. When he takes his temperature, he gets a reading of 101.2 degrees Fahrenheit orally. He still feels a little bit short of breath and decides that he will call the clinic in the morning. In the meantime, he goes downstairs, sits in the recliner, and naps fitfully. When Mr. Bly gets to the clinic, the doctor performs a chest x-ray, which shows pasty infiltrate in the lower lobe, his CBC with differential, elevated white blood count with differential showing a shift to the left, indicating a bacterial infection, and his arterial blood gases show pH of 7.32, PaO2 52, BaCO2 48, and bicarb is 30, and diagnoses Mr. Bly with pneumonia. He's taken to the local hospital and admitted with orders for intravenous fluid, a high-calorie, low-salt, low-fat diet, oxygen via nasal cannula, 2 liters, and he's on cefaclor, 500 milligrams IV every 8 hours, and aminophylline, 100 milligrams POQ 8 hours, and Atrovent HFA 2 puffs QID. Well, as you can see, Jimmy, because of his age, because that he smokes, he's now developed pneumonia. So he is at risk, he's immunocompromised, and he's developed what we call bacterial pneumonia. So he was admitted, and I'm sure the reason they admitted him was because we wanted to give him IV antibiotics, and definitely because he's older and he's at high risk for developing complications. So we're giving him fluids because he does have a temperature, so we want to keep him properly hydrated, and then of course obviously repeat these chest x-rays. Look at his ABGs. I want you to think about what those represent. So I want you to think in your mind, what kind of problem does Jimmy Bly have? First of all, his pH is 7.32, which indicates that he is acidotic because the pH is 7.32, going to the left on the curve below 7.35. His PaO2 is 52, which definitely determines that he is hypoxic. His PCaO2 is 48. It's not severely or highly elevated, but it is a little bit out of the range, so he is in respiratory acidosis, and his bicarb is up a little bit. That other system is taking over and trying to compensate. So this is very typical of somebody who does have pneumonia. Think about it. Diffusion of gases has been compromised, so that's why his PaO2 is very low and he is hypoxic. Okay, so it's good that he's on some oxygen. He's on 2 liters per nasal cannula, and of course he's on antibiotics. He's on aminophylline, which will help relax that smooth muscle and allow better airway flow. And then he's on an inhaler as well. So hopefully Jimmy gets better with this regimen of treatment, and we can think about some other types of intervention. So the next question I have for you after reading this is, what factors contributed to the decision to hospitalization instead of treating him at home? And I think I've pretty much covered that. He is a high risk, he's older, he's 78, and he already has moderate emphysema as well. Okay, and he's a smoker. And why would the physician order oxygen in only 2 liters per minute instead of 100% mask at 6 liters. This has to do with the fact that he does have emphysema. I'm not going to get into this. You'll learn more about COPD and Nursing 122, but you don't want to give patients with COPD or emphysema high levels of oxygen because it could knock out their hypoxic drive. So that's why we just keep them on 2 liters. Develop 3 nursing interventions for this patient. I think we could use many of the interventions that I just talked about on that appendix. What was it? The appendix 21 that had to do with nursing interventions and the rationale behind them. I think positioning, encouraging coughing and deep breathing, maybe some respiratory treatments, making sure he's getting plenty of fluids. He's got a high fever. We want to obviously assess intake and output, being that he's older. And we don't want him to become dehydrated because that's a very a high risk for a patient at his age. And also we want to hopefully prevent him from developing many of the complications that I talked about that were in the PowerPoint. Septicemia, pleuritis, pleural effusion, empyema, and all these things that could eventually become much more serious and prevent the patient from getting well. So I wanted to share that with you. So that pretty much concludes this lecture on oxygenation, where our exemplar was pneumonia. I hope you have a better idea of the seriousness of pneumonia and to look at some of our patients out there who are at high risk for pneumonia. I also want you to really understand arterial blood gases. It's not something that you can learn just in a quick, easy read. I want you to review your assigned reading, and I want you to make sure that you pay attention to the table on page 6. That maybe helps you to understand these particular situations when we see these blood gas results come back. Maybe if you relate that particular result of a blood gas to a patient situation, it might make more sense to you. This is a great way to kind of think about that particular problem with arterial blood gas as to how the patient might present. It talks about imbalances related to metabolic acidosis, where there is an increase in acid production. And one common patient presentation of this problem is when patients come in with their diabetes and develop ketoacidosis. Metabolic alkalosis is when you have somebody that presents as losing a lot of acids through the GI tract. And then respiratory acidosis, that's probably one of your more common presentations, when that's patients with chronic respiratory problems such as COPD. And then respiratory alkalosis is anxiety-induced hyperventilation. And a perfect common example of that is when somebody has a panic attack and starts to hyperventilate, they will present as somebody who develops respiratory alkalosis. So please go over that. Remember, do not look over anything about compensation. We will not do that in Nursing 121, okay? So I hope this helps you. If you have any questions about any of this, I'd be glad to answer them or call you on the phone, and we can even go over some questions in our WebEx meetings. So have a great day, and thank you for your attention.